climate
This conference will now be recorded.
In the current climate where people have access to a lot of information, the task of clarifying the added value of DNA fragmentation test is easier said than done, but we can only try. This very eminent medical statistician, but he's more than medical statistician. He is more of a philosopher and advocate of proper research, and he's one of the most eminent figures in biostatistics in the UK, or he was, because sadly he died about a couple of years ago. And he described this long time ago that it is a scandal to have poor medical research that can be by default or design misleading, and then people can make decisions based on that suboptimal or poor research. And his recommendation was, we need less research but better research, and research done for the right reason. And when it comes to DNA fragmentation tests, like other tests, like other intervention, you find wildly conflicting views. People who are enthusiastic on testing and like to do things because it sounds fancy and it sounds attractive will always be enthusiastic. And those people who are looking for value and looking for implication, they will be probably spending the money wisely, even if it's not theirs, their patients' money. And because of all of this background, there is a state of confusion. And we all agree, number one, nobody possesses all the facts, because we all have our failings and our flaws. But even when we have what we believe to be facts, most of the time they are relative. They are not absolute, and we need to get hold of this fact. More importantly, we need to appreciate that infertility most of the time is relative, and to find absolute infertility is less common than the relative one. And the issue of relative infertility has been recognized long time ago. Robert Jansen, who is a pioneer in assisted reproduction and infertility, I'm not sure whether he's still alive, from Australia, published a paper in Fertility Sterility in 1993 talking about relative infertility and the clinical paradoxes that happen. And to just put it in simple terms, how many times you have a patient who has been trying to conceive for a couple of years, and when she plucks the courage to come to see you with a view to treating, she will find that she has a positive test on the day of the consultation. It's not because you have magic or you have given her some divine power. It is just because by chance any degree of infertility is resolvable. And in that analysis, he did something very interesting where he looked at the chance of spontaneous conception, or the cumulative probability of pregnancy, related to the type of infertility, to the duration of infertility, to the age, and so on and so forth. So if you find here, when infertility is less severe, mild cause, minimal pathology, you find that the chance of spontaneous conception over 5 years is extremely high. And most of the pregnancy happen in the first 2 years. When it is so severe, still it is not zero, but the probability of having spontaneous pregnancy becomes less. So with whatever diagnosis we make, whether it is tubal, whether it is male factor, whether it is unexplained or ovarian, there is always the chance of spontaneous conception. And why I spend some time on this? Because that's what clouds everybody's judgment. You give an intervention and the patient gets pregnant, you will never think of that relative infertility. You will attribute the success, the pregnancy, to the treatment that you gave, even if it was irrational, even if it was irrelevant, even if it was not biologically plausible. That is before treatment. How about after treatment? There is an interesting study that incidentally was published by a fellow Egyptian consultant in London who has been working in infertility for quite some time. I think he's retired now. His name is Samuel Marcos. And he surveyed women who had IVF that didn't work. And 1/3 of the patients who responded out of the 400, 3 responses, 34 of the 96 women who did not fall pregnant after IVF fell pregnant after IVF failed. And most of these pregnancies happened also in the first 2 years. So before IVF, it could happen. With IVF, of course, it could happen. And even if IVF failed, spontaneous pregnancy is still possible. And you will find that 90% of the patients fell pregnant within 2 years after failed IVF when they stopped treatment. So fertility treatment is more widely available now. It seems that we are increasingly using it for shorter duration infertility and for less severe cases like unexplained infertility, mild male factor, and mild endometriosis, where it is not absolute. So the window for opportunity is still available to patients even after IVF had failed. So the subject matter here is DNA fragmentation test. Does it add value? And it is a split of opinion. Some of us will say it doesn't. In this case, it is useless. And some of us would like to argue that it can be useful. So let's just start by context setting. Where does DNA fragmentation come in terms of fertility investigation? We know that we all do semen analysis, and the patient will be referred with the result of the semen analysis. And that is just the first port of call. And it's clear that it can discriminate between fertile and infertile men by the standard that the WHO has set for us. I will come back to this later. And of course, it correlates with the probability of conception. Look at this paper published in The Lancet maybe 20 years ago, where when you correlate the sperm concentration, when it is very low concentration, the chance of pregnancy becomes less, the probability of becoming pregnant. But when the concentration increases, the probability of pregnancy becomes higher, and so on and so forth, of course, until it reaches maximum level where there is no addition of that care. So it is not that waste of time. However, you can see that over the years, there has been modification of the values. And in 1998, in 1980, 1987, all have been reviewed of the parameters of what constitute a normal sperm test, until we got the latest one, which belonged to 2010, where we know the figures like concentration of 15 millions and morphology of 4% or more and motility of 32%. And when it comes to defining what is normal, it's really a huge range, because if you use the 2.5 centile, it could be concentration as low as 9 million per ml could be normal. If you go to the 75%, the 75 centile, then you can expect 116 million per ml and so on and so forth. And the same variation, but the one in the middle here is the one that is reflecting the current WHO criteria, volume 1.5, count 15 million, and total motility is 40, but the progressive motility is 32, and normal forms 4%, and vitality 58%. And this is based on data from 1900 men with proven fertility, and the time to pregnancy was less than 12 months from 14 countries. So sperm test gives us an idea, but it is not totally accurate, meaning that you could find a man with a sperm count of 5 million and he's perfectly fertile. You would not know before if you didn't do that for research reason. Equally, you could find a man with the right parameter, but in the absence of female factor, still he is infertile. So because of this, the quest for better tests is very legitimate, and it is really, it makes sense. And there has been a whole host of sperm function tests, or so-called sperm function tests, old audience like myself will remember that you heard about hamstring zona test, and even the post-coital test. I don't know whether people are doing it or not nowadays, although it's a waste of time, I must say, and so on and so forth. There were so many sophisticated laboratory assays. All of these have nearly vanished, and we are left with sperm DNA assessment. Unfortunately, before we go into the details, there is no consensus in the appropriate test. Which is the best test of the available DNA fragmentation testing? Which specimen to test is better? Do you do the raw semen or do you do the prepared semen? And what is the abnormal level of fragmentation? And how did you validate this abnormal level? Is it just by arbitrary from your receiver operator curve for your limited sample size? It is population. Did it include normal as well as abnormal, or it was related to just the infertile patient? All these questions sadly remain unanswered. So what's DNA fragmentation? DNA fragmentation is decidedly a biological physiological process where during the process of spermatogenesis and spermiogenesis, there will be some single and occasionally double strand fragmentation. As you can see the fragment, this is the DNA and this is a histone, and there could be fragments along the way. And the sources of DNA fragmentation, thanks to this comprehensive detailed review by Denisakis and Alvarez, published in Fertility Sterility in 2010, it highlighted to us the source. And it's important to remember that because it could happen during spermatogenesis itself. It is part of the process to have apoptosis, and for as long as there is apoptosis, there will be DNA breaks. It could happen during spermiogenesis, which is the final stage before making spermatid and then sperm. And it could happen by endogenous caspases and endonucleases. And it could also happen by acquired insult to the testes, like damage induced by radiotherapy or chemotherapy, of which we are all aware. And that's why we freeze sperm before we expose men to this treatment if they are to be treated for testicular cancer, for instance, or for any reason. And DNA damage also can be induced by environmental toxins. So there are 5 threads to DNA. There is the one that happened during spermatogenesis. There is the one that happened during spermiogenesis. And that's why even if you go and get testicular sperm before passing through anything, you will still find some degree of DNA fragmentation. But if there is additional insult like infection or like this kind of environmental or drug related, then you could find this. And there is the place after that is in the epididymis. There is some degree of spermiogenesis, of DNA fragmentation. People say it is because there is immature and mature sperm and they are retained for some time, and that could trigger. It's not really clear. It could be in the vas deferens, and of course, it could be in the ejaculate. And that is the post-testicular DNA fragmentation via exposure to reactive oxygen species. So when we talk about apoptosis, is it normal or abnormal? I mentioned earlier that it is really perfectly accepted and understandable principle that this is a process of programmed cell death, and it is mediated by its own mediators within the testis, and it is an essential phenomenon to maintain homeostasis and to help with the modeling of what happens inside the testis, and also it plays critical part in immune response and getting rid of dead, whether it is sperm or even earlier stages. One of the steps during apoptosis is DNA fragmentation. So some of it is occupational hazard. It is likely to happen for good reason. Some of the demonstrated fragmented DNA are in the cells that are in the process of death. So we could be getting the wrong end of the stick by making judgment on the level of DNA fragmentation that's part of a perfectly natural process. So when it comes to testing, and when we ask ourselves whether to test or not test, we need to just go back and ask ourselves, in which clinical scenario do we request DNA fragmentation tests? And we need to remind ourselves, patients don't come to us for tests. They come to us because they want a baby. So if whatever we do, testing or otherwise, will bring them closer to achieving what they came to us for, fine. But if it is something just for curiosity of our own, the patient should not pay to satisfy our curiosity. If it is something that we will really not change what happens after meaningfully, then patient should not pay for us experimenting and failing to make the right judgment. So let's just remember, patients don't need tests. They only want a baby at the end of it. So it's important, you may have heard this from Stephen Covey, which one of the 7 habits of highly effective people, but in this context, we need to always begin with the end in mind. It's not test for the sake of testing. Does this form a milestone or a stepping stone in the way to helping achieve success for this couple or not? But if it is just for a little bit of show, because with the word DNA, that you are really getting molecular here, and it is a bit sophisticated, but does it add value? That's the question we need to ask. We all know the clinical performance of any test, depending on prevalence, sensitivity, specificity, and all of that. But to just put them all together, let's talk about the accuracy in predicting the outcome. Here is the test in the market. These are the tests in the market. Let me just draw your attention here that when you do the receiver operator curve or characteristic curve, when you do that, it is the one that gives you an idea about whether this test is worth investing or not. If the test is here, where you find it is, say, 0.88, 0.9, just like other tests that we use on daily basis, I will not mention not to distract you. But if the test is like this, where the area under the curve is 0.54, that is just flipping a coin will be just as good, except that it's not expensive, it doesn't cost anything. You just need a coin. So you can look here, whether it is CASA, the ROC is no, or the area under the curve is not great. Whether it is Comet, it does not appear to be really very convincing. Whether it is Tunnel, it may be a tiny bit better, but still, nonetheless, it is probably at best will be about 60. So it's important to remember that. And it needs to add real value by telling me something that I don't know. You will find people saying, oh, doing DNA fragmentation will identify infertile men. But they are coming to me because they are infertile. Why am I stating the obvious? And then if they are infertile, what will I do? They are coming to have ICSI. So what difference would it make? But we'll come back to this later. But let me remind you, having the facts in your hand or the position of the facts is knowledge. But the use of this knowledge is wisdom. And if we use the knowledge that we have with a little bit of focus and concentration and wisdom, then we will be really serving the patients well. So what is the impact of DNA fragmentation tests? And when they are abnormal, is this abnormality modifiable? Can we do something about it? Let's just see the impact. And I will start not from the beginning, but from the end. This is a good meta-analysis and systematic review published by my friend Ari Kumarasamy from Birmingham. He's very accomplished with this kind of research, and his team, and it is including 2 eminent andrologists, Sheena Lewis, whose company market the Comet test, and David Miller, who is a reader in andrology in Leeds University, who we did the HAP Select trial with. So they are all really good people. But look at the result of their analysis when it shows that DNA fragmentation is associated with increased miscarriage. A variety of tests. B, which is more remarkable, look at the cutoff point or figures for abnormality or normality. It has to be under anything above 15 or above is abnormal. Anything above 27, it is abnormal. Above 30 is abnormal. Above 10 is abnormal. So you can see for yourself the mishmash of cutoff point, the mishmash of studies in terms of number. There is a study here that included 18 patients. The mishmash of design, there is prospective, but there is retrospective. And more importantly, actually, there is unpublished results here. So it is important to look at these things. So when it says there is association between the level of DNA fragmentation and miscarriage, we need to ask yourself, does this ring true with the observation or what is being published? And let me show you one of the studies that we did. It was looking at something else, but as a result, we were looking at miscarriage in relation to ovarian stimulation. So when we divided patients that we looked at according to indication, this is a group with female cause, but their infertility was secondary. Okay, and here this female cause, and this is male or unexplained. I hope you agree with me that this male factor or unexplained is the group that is most likely to have plenty of DNA fragmentation if the emphasis that people are making is to be believed, because male factor surely is associated with high DNA fragmentation, and unexplained there could be partly due to some undiagnosed high DNA fragmentation. So you would expect this category at any point to have higher rate of miscarriage compared to when the infertility is due to a female cause. But look here, whether the patient responded suboptimally, meaning 3 or fewer eggs, or whether the patient produced 4 or more eggs, any number, the miscarriage for patient under 37, 38 to 39, 40 to 42, 43 to 44, for the female cause, all the figures appear to be marginally higher than male factor and unexplained. What does this tell us? It tells us that with this group, which is expected to have high DNA fragmentation among those men, you don't see any discernible increase in the incidence of miscarriage. The same for, say, normal responder. Here is male factor, and here is a miscarriage, and here is the female cause, and here is a miscarriage. And when it is primary infertility, it is the same. All the time, the figures on the female side are just marginally higher than the male and unexplained side. So that is an indirect evidence that the observation made on the meta-analysis probably not watertight, not because the people who did the study, they are bad, but the studies that they have included, unfortunately, were heterogeneous, with different technology, with different cutoff points, and with different design, and all what I have just explained. But even if it was true that it is associated with increased miscarriage, does this mean that DNA fragmentation is causing the miscarriage? I hope you would agree that association does not mean causation. When studies find association between two things, it does not mean that one thing caused the other one to happen. And we know what happens with correlation. You can correlate anything. You can correlate the height of the buildings that you have in the street to the blood pressure in the people in that street. It means nothing. Okay, so without sense check and biological plausibility, it becomes just a statistical anomaly. I'll give you an example. Here, as we are entering summer, when weather is dry, hot, and sunny, and summery weather, there is more likelihood of sunburns, particularly when people indulge in the beaches and proper exposure to the sun, or overexposure, I should say, then they get sunburn. But also when it's hot and dry, people consume more ice cream. So it follows there will be correlation between sunburn, or the incidence of sunburn, and the consumption of ice cream. Does this mean that ice cream is causing sunburn? Does this mean that sunburns are causing ice cream? There is absolutely no relationship whatsoever. It just incidentally, they follow each other. More probably funnily, on the funny side, now if you look at all the astronauts who made it to the moon, they were found to all have chicken at some point or another. So does this mean that chicken makes people go to the moon? That is the kind of correlation and its relationship to causation. So one of the companies that promote DNA fragmentation, again, they are very good people and they are scientists and dedicated to this field, but they are writing here on the website, the clinicals, or in their publication, the clinical threshold for diagnosis of male infertility and prediction of success of IVF have been established by those studies. So you would feel the whole issue is settled. Why are we concerned about it? If it says they have been already established, the prediction of success with IVF and the diagnosis of male fertility. But look at, it is hard, it's not meant really to be read because it's so busy. But if you look here again, the story again, the cutoff points are anything from 10, 20, 4 to 10, 15, 44, 27, anything. And with ICSI, with IVF, with IUI, with it is also a mishmash of a combination. Can this really advise anyone if it is all so heterogeneous like this? One of the papers that Professor Sheena Lewis and her collaborator published, sperm DNA damage or progressive motility. Which is better? Would you rather have sperm that on the face of it has good motility, or less motility a little bit, but better DNA fragmentation? And the study, for some reason, showed that fertilization rates are directly dependent upon both sperm progressive motility, which one can understand, and DNA fragmentation. But sperm DNA fragmentation is much stronger. Now, if you read all the literature, probably bar 1 or 2 studies, they say that DNA fragmentation has no impact on fertilization. It has no impact on embryo development. It has no impact probably on implantation, but the only bit, because of that correlation with miscarriage, it leads to miscarriage. They also go on to say, if you are doing IVF in the presence of high DNA fragmentation, you better advise to do ICSI, because the result will be better. The difference in miscarriage rate will disappear. Now, when you reflect on this fact, in a culture like this, where ICSI is done for everyone, what is the benefit of doing DNA fragmentation if this is the only implication, which is questionable? So that is one thing to say. So when you look at literature, sperm with DNA damage are capable of fertilizing the egg. That's John Etkin and others have established that it has no bearing on the fertilization because it will be injected inside and the cascade of fertilization would happen. And then, because of that discrepancy, this may explain why studies evaluating the relationship between DNA fragments and pregnancy rate have only found modest effect on conception rate with conventional IVF, but little or no effect with ICSI. And this is a whole host of studies that showed if you are doing ICSI, high DNA fragmentation has no impact on the outcome whatsoever. This is a systematic review and meta-analysis done by Madeleine Van Wille and group in Amsterdam, and measuring DNA fragmentation tests. And here is the bottom line from this. They concluded that sperm DNA fragmentation tests have limited capacity to discriminate between couples with low chance to conceive and couples with a high chance to conceive after medically assisted reproduction. They also concluded that sperm DNA fragmentation have little or make little or no difference in predicting the outcome between IVF and ICSI. When you look at the American Society for Reproductive Medicine and its practice committee, it says really here the current method for evaluating sperm DNA integrity do not reliably predict treatment outcome, and no treatment for abnormal DNA integrity has proven of clinical value. So that's the bottom line. If you don't have treatment that is proven, the test is negative or positive, what are you going to do about it? Also, the more updated consensus from the same committee, we talk about sperm DNA damage is more common in fertile men, which is to be expected. Sperm DNA damage is also associated with spontaneous. They are referring to that meta-analysis, which I hope I have exposed and dissected to you. And also make sure you are aware that you are using the word association, which we agreed it doesn't mean causation. Okay, and then the existing data about the relationship between DNA fragmentation and the outcome is